Perfect. All right, let me elongate this so I can see all of your faces respond to what I say. All right, here we go. So this is acceptance and commitment therapy added to a CBTP program. How many of you are familiar with acceptance and commitment therapy? Okay, a little bit. So acceptance and commitment therapy is a really interesting way to work with CBT concepts. So it's still a CBT oriented therapy, but it incorporates a lot of mindfulness and acceptance in a way that we don't usually think of acceptance. What I'm going to present to you today is a little bit about a group that any agency could implement that's an ACT group for psychosis. It's called Act for Life. And there's actually a book, Act for Psychosis. And it's actually got the protocol right in it to do this. And I rewrote the protocol. Well, we'll get into that. Anyways, what I'm going to introduce to you today is a group representation of ACT. And this can be done by master's level providers. In the book, where the template is for this, it says that case managers could sit in and do this, and they could if they had a good understanding of psychosis and some good education behind that. I don't think people necessarily need to be licensed, but they need to be working with a master's or above therapist to do this. So it is a third wave approach. And is that little thing in there we go. Can do that. It is a third wave approach. So it incorporates mindfulness in a big way. And mindfulness can be done with people with psychosis really quite easily. There are some restrictions to it. It has been shown to really improve quality of life and recovery rather than just symptom reduction. So it's very similar to CBT in that way. And it just adds a different approach to addressing psychotic symptoms. So this is a limited time group, and we would incorporate a limited amount of group members and have it be closed for a period of time. It provides really it can be used as a standalone intervention. In other words, you could do this within another group, or you could do this even individually. So we look at mindfulness processes and commitment to value-directed behavior to produce the behavior change. We're also looking at, of course, greater psychological flexibility, because folks with psychosis and delusions certainly are so fused with that delusion. It's really difficult for them to separate delusion from reality. So for example, and we do this too. So for example, how many of you would say that the sun rises in the east? This is an example of a Okay, you've heard me ask this question before, I'm guessing. The sun does not rise in the east. We revolve around the sun. But when I ask a group of people this, psychosis or no, they all say, yeah, the sun rises in the east, because we've become fused with that idea, because that's what we think of every day. We don't think of the reality that the earth is going around the sun, and that's what causes the sunrise, right? So that's an example of how every day we can be fused with an idea that's not based in reality. When we work with cognitive restructuring, that's a really great way to begin to have people think about how they're not reality-based ideas are different than reality based. So we can influence how somebody reports their experience of reality. Um, and so researchers were wondering, is it really the cognitive restructuring that changes things? Is it the behavior that changes things? And we all know that a lot of our clients, psychosis or no, have been through many self-help groups, read many self-help books, have gone to many group therapies, and continue to come back for therapy. And so it's working, but it's not somehow, right? Because people aren't fully coming into their own recovery. So they keep coming back and keep doing things and picking things up, picking interventions up along the way in their life course. And that act of trying to get better then becomes the problem because they get addicted to the problem. They say to themselves, I'm not doing this right. I'm not doing it good enough. And so ACT is really more about being with the problem rather than trying to fix the problem. So if we think of psychosis, people are thinking of all kinds of ways to get rid of their voices, none of which work, right? And so this is about teaching people not just to live with their voices, but to live with any unhealthy negative thinking that they may have. This is the kind of complex part of ACT. The way that the model is laid out in what they call a hexaplex. And there are relationships among all of these points on the hexaplex. Let me see if I've got more. No, I don't have more slides of that. If you read the book, it will highlight for you how all of these relationships occur. But we can see here, for example, acceptance versus diffusion. That's kind of a scale, right? So it's not acceptance versus diffusion because acceptance requires that we let go of that locked in sense that we have with our negative beliefs, right? So that's called, when we're locked into a negative belief and we are that negative belief, that's called fusion, right? So that's, I am a mess, I am damaged. Acceptance and diffusion says there's a part of me that feels shame and worthless. And so I'm going to sit with that for a while and see what I can do with that now that I've accepted that. And the way to do that, of course, when we talk about people who are rigid with delusions is, well, if we can't fix the delusion or influence that in any way, then we go to what else is going on in your life that you would like to improve. And in acceptance and commitment therapy, that's called contact with the present moment. Even though all this stuff is going on in your head, what is your goal for life? What do you want to do right now? It's also values based. So it's not just, I'm going to do this because somebody told me to. I'm not going to just go to AA because that's what my therapist said. I'm not going to, do this, that, or the other thing because that's what the program requires. I'm going to do something because my values are important enough for me to act on that. And so if there is a valuing of wanting some peace and wanting to move forward in life, then those are the values that we're working with. Of course, there's got to be willingness, which is very hard with psychosis because they have to be willing to sit with some pretty horrific things. And then we need to be able to also talk about how a person is really, stress is a main trigger for schizophrenia and psychosis. We have to take into consideration where this person was when onset happened, how stressful the situation was, and what are the continuing triggers in their environment so that we can normalize what's happened to this person, right? For many of us, if we were in those situations growing up and in those dysfunctional homes, we might have, our mental brain might have flipped that switch, and we might have ended up with some psychosis given the amount of our vulnerability to stress. So it really hits on a lot of important points in doing therapy. We want to create a willingness to do this. We want to make it not fun, but adventurous, and to incite some curiosity in our clients. We want to reduce that chronic need to avoid their symptoms. We do use guided meditation, and we ask clients to notice the psychotic sensations without trying to do anything with them. Okay. We normalize it just like our own negative thoughts or our own compulsions or urges. Those of us who are well trained in that and have a committed action, we notice the urge and we move on. We surf over that. So this is what we're trying to do with folks with psychosis. And of course, like all of us, the sensations and the experiences come and go. Psychotic experiences are not considered special in any way. It is just part and parcel of this person. And they're learning to figure out how to manage and direct their life with those symptoms on board, because we all know that sometimes the symptoms never go away. What we've recognized is that when we can teach patients to do this, it helps them to get some distance between their symptoms and who they perceive they are personally. The symptom reduction, guys, is not the goal. It's not the goal. What's the goal is building recovery and a meaningful life for them, whatever that might be. So we want to teach the client how they are actually interrupting themselves, how they're stopping themselves from living a good life. In fact, by trying to get rid of the voices, which just seems paradoxical. So we help them recognize habitual responses, and we introduce alternative ways of letting go. There is this is the manualized thing that I was talking about in the Act for Psychosis book. This particular group really had some great effect sizes, 0.4 for helping people not to interfere with their symptoms. Mood, experiential avoidance was reduced, cognitive fusion was reduced, and mindfulness increased. So it is possible to have some really good effects. And in research, what we've discovered is when doing a study on readmissions using treatment as usual versus ACT, that over the course of 1 year after discharge from hospitalization, the risk rates for returning to the hospital under treatment as usual for the group increased by 229% over ACT at day 120, and that increased to 254% over the rehospitalization rate of ACT in 1 year. So we can see that the benefits continue to mount even after the treatment is over. The survival treatment effects from day 120 through 365, in fact, then grew. Between group differences in this particular research were insignificant, which means that for sure this treatment was in fact being very effective. So in the book, Act for Psychosis, and I can show you that, I don't have it right on my desk. It was originally written for 4 1.5 to 2 hour groups. But we all know that working with psychosis is a little difficult and takes a long time. So what I did was I went into the curriculum written in the book and I rewrote it for 8 sessions, 2 hours apiece with a break in between. I followed the manual as closely as possible. So I actually did this group at CSS. And we used a metaphor called passengers on the bus. ACT uses a lot of metaphors in therapy. It's just really helpful to do that. We selected an ACT, that's hard, an assertive community treatment team population to do this. All of the clients were interested in cooperative, and there were 8 participants, and lo and behold, voluntary as it was, all 8 participants came back regularly. Just as a note, when I introduced this to the CSS population, do we have anybody here from CSS who's a therapist there? When I introduced this to the team leader and the case managers, they were like, this is never going to work. People aren't going to come back. They're not going to understand. You're going to fall flat on your face. We don't think it's going to happen. And I was like, okay. So we did it anyway, and lo and behold, they all came back. So here are some examples of the things that we do in group therapy. The group requires that we do a PowerPoint to introduce people, give them a visual representation of what we're talking about. So in the beginning of group, we do a warm up of 3 things I love to do, 3 things your partner loves to do, and we break up in dyads and then have people report on that. We might do some mindfulness breathing, and then we get into talking about personal values, right? So the behavior that we have is just a tiny bit about, of the process of behavior, because our values are really big. We don't talk about values much in our culture. So we bring up values as kind of a new and novel thing to work by. The metaphor that we're using here are passengers on the bus, and that's what this whole group is about, is managing passengers on the bus. Tim, I see you nodding your head. You're familiar with this. There is on the ACT website, there's actually a really good little video of passengers on the bus, which I will show. Tim, you've seen that. And basically what it's saying is that we're, the person who has psychosis is the driver of the bus, and they have all these people in their bus, and the people represent voices. And so they may have a bunch of voices, they may have one voice, but those voices are on the bus, and they are dictating where the bus driver goes, not the bus driver. And so what we do is we do a role play in group with that actual metaphor. So we ask somebody to be willing to work. That person becomes the driver of the bus. And we ask the remaining group members to portray the voices. And the client, the working client, will give the other patients lines to say that represent their voice. And then I get the person up there, and they're driving the bus, and I ask them where they would like to go in life. What would they like to do that's new and different than they haven't done? In this particular group, the person said, I'd like to go get ice cream. Okay. So he's in the bus, and he's got his passengers, and the passengers are saying, no, you can't go get ice cream. You'll make a fool out of yourself. Another line was, you're gay. Everybody knows you're gay. You're going to embarrass yourself. So the clients were actually on this assertiveness commitment team, this ACT team, were more than willing to portray the voices of this driver. And the driver tries to tell them to shut up. And the instruction is to the passengers on the bus, don't shut up. Then the instruction is, can you kick them out? Well, that's not working either, right? They might recruit one voice to get the other voices back in order, right? That doesn't work either. So they want to go to the ice cream store. This guy wanted to go to the ice cream store, but his voices were just giving him no leeway whatsoever. And it got to the point where this one person actually turned around and said to the guy whose line was, you're gay. I am not gay, and I'm going to the ice cream store. And then he went back and all the voices were going, and he was able to just say, I can do this without listening to them. And this was actually a person in the group that was Harry's individual client. And I think Harry, if I'm not mistaken, he actually took some risks after that group and went walking with you in ways that he wouldn't have ordinarily. So we ask, you know, we say things like, you're the driver. These voices are your thoughts, your feelings, weird noises, whispering, whatever it is that they might be. And we can even use physiological things in there as well. Come on. Oh, I did this thing with, yay, okay, great. So what we do is we say, okay, you want to do this thing. What are the values that you're operating off of that make you want to go to the ice cream store? Well, I want to have fun. I want to participate in life a little bit. Okay, well, that's different than I want to get rid of the voices, right? What are your goals? I want to be able to be with other people. I want to do a normal thing. And so in order to do that normal thing, what actions are related to that, right? And then we teach people to go ahead and make their valued directed behavior despite all the voices in the room or on the bus. We talk about in the group how our passengers can divert our valued direction. And I talk about my passengers as my negative thoughts, which they are truly my passengers. We listen to the passengers, we listen to the thoughts, we believe the thoughts, we give in to them, voices, we struggle with them, we try to throw them off. And yet we want to highlight the clarity about where they want to go and making a mindful choice, an intentional choice to do that rather than to try to fix things in the background. Teach them that mindfulness can help you choicefully make decisions in your life, that it doesn't need to be all knee-jerk reaction. So we allow the passengers to ride the bus, but we think about ways to not engage with them so that we can take the bus wherever we want to go. So the pilot group that we did with this had these 8 clients, and they were not screened. They were all voluntary. And I did have a co-facilitator who was largely inactive because she was not familiar with the ACT protocol. So it was basically me doing it by myself. And the 8 participants did actively involve themselves in the role play. Not all of them took the place as the driver, but they ended up encouraging each other. They clapped for each other. Interestingly, the staff of the agency had never seen this before, were not so excited about the role plays. They were thinking that this was going to kind of arouse things, but it didn't. It allowed for some insight and some development on the part of the clients. They started laughing with each other and being humorous and shared a little bit more about their life histories than they otherwise might have, particularly in a group. So here is the example of the client that turned around and said, "This is ridiculous. None of you are right. I'm not gay." That was an anecdotal outcome. The other thing was all the breathing exercises that we did. I was thinking, boy, they do those and then they kind of forget about them. But when case managers were giving clients rides home after the group, they noticed that the clients were actually practicing the breathing with each other in the car and remembering that months later, which I thought was just really cool. And then shortly after the group and they had seen these effects, one of the case managers came up and said, "I want to know more about ACT because I see changes in the clients that were in that group." So all in all, it's an excellent opportunity to introduce a new way of working with psychosis that turns CBT a little bit on its head, but it's still CBT. It is recognizing that the thoughts are there, recognizing that the voices are there, and choosing to be with them rather than to fix them and to move on with a valued life. Um, it's short, it's a short group. You could do it with, again, you could do it with a non-licensed co-facilitator who's familiar with this. It's possible to do this in your agency. It used to be when I was an employee at Neomed that I would be willing to go out and do this. But if any of you are interested in that, I would urge you to get a hold of Harry. And then he can pass on to me and we can find ways of getting that information to you. And so I would like to ask for feedback and questions.